Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Long-Term Risk of Subsequent Malignant Neoplasms After Treatment for Childhood Cancer in the DCOG Later Study Cohort, Role of Chemotherapy, by Teepen et al. My name is Lucy Turcott, and I'm an assistant professor of pediatrics at the University of Minnesota in Minneapolis, Minnesota, USA. My oncologic specialty is pediatric oncology. Subsequent malignant neoplasms are highly morbid late consequences of childhood cancer therapies. Survival following a childhood cancer diagnosis now exceeds 80%, meaning the population of survivors is rapidly increasing. Research of large cohorts of survivors from the USA and Europe have allowed for the identification of risk factors for various late effects, including subsequent malignancies. Therapeutic radiation, although highly efficacious in treating multiple childhood malignancies, is a particularly toxic therapy in terms of risk for late effects. Exposure to therapeutic radiation as a part of childhood cancer treatment is associated with significantly increased risk for subsequent malignancies, particularly for malignancies developing within the radiation field. These relationships have been well described and occur in a dose-dependent fashion for multiple solid tumor types, such as cancers of the breast, thyroid, central nervous system, and gastrointestinal tract, as well as non-melanoma skin cancers and sarcomas. Over time, pediatric oncology cooperative groups have altered primary cancer treatments to reduce the number of children exposed to radiation and also to reduce the cumulative dose of radiation when it cannot be fully eliminated. Specific examples of this include the near elimination of cranial radiation from childhood acute lymphoblastic leukemia treatment and the response and risk-based use of radiation for Hodgkin lymphoma. Despite the reduction in radiation exposure, the risk for subsequent malignancies among survivors of childhood cancer remains greater than the general population. This has led to growing interest in describing additional subsequent malignancy risk factors. Treatment-related leukemia has been described as a result of exposure to alkylating agents, epipodophyllotoxins, and anthracyclines. However, an association between specific chemotherapeutic agents or classes of agents and subsequent solid malignancies have been more difficult to establish secondary to frequent concurrent radiation exposure. Recently, a report from the North American Childhood Cancer Survivor Study described an increased risk of breast cancer among female survivors not treated with chest irradiation and suggested an association with high-dose alkylating agent and anthracycline exposure. While these findings are compelling, individual chemotherapeutic agents were not investigated, and other malignancies beyond breast cancer were not explored. In the present study, Teepen and colleagues examined the risk for chemotherapy-associated subsequent malignant neoplasms within the Dutch Childhood Oncology Group Long-Term Effects After Childhood Cancer cohort. The cohort consists of 6,165 5-year survivors of childhood cancer diagnosed before age 18 between 1963 and 2001 at one of 7 Dutch pediatric oncology centers. The median follow-up within the cohort was 20.7 years since diagnosis, and the median attained age was 28.1 years, and 103,949 person-years of follow-up were accumulated. The most common primary diagnoses in the cohort were leukemia, which accounted for 34% of survivors, lymphoma at 16%, and CNS tumors, which made up 14% of the cohort. Treatment with radiation decreased from 75% in the 1960s to 1970s to 28% for those treated from 1990 to 2001, and exposure to chemotherapy increased from 72% among those treated from 1963 to 1979 to 80% for those treated after 1980. Within the cohort, 261 survivors developed a subsequent malignancy, representing approximately a 5-fold increased risk of malignancy compared to the general population. The greatest excess absolute risk was seen for breast cancer, thyroid cancer, soft tissue sarcomas, and central nervous system malignancies. Although the standardized incidence ratio decreased with increasing follow-up and attained age, it remained elevated at 3.8 even beyond 30 years. The 25-year cumulative incidence of a subsequent malignancy was 3.9%, and when treatment decades were compared, the 15-year cumulative incidence of subsequent malignancies did not decrease significantly for those treated after 1990 compared to the earlier decades. In multivariable Cox regression analyses, treatment-related risk factors were evaluated for all solid cancers and then specifically for subsequent breast cancer and sarcoma. Total body irradiation and any radiotherapy other than total body irradiation were both associated with an increased risk for developing solid cancers. Doxorubicin doses greater than 271 milligrams per meter squared were associated with an increased risk for solid cancers, with hazard ratios of 1.8 for doses of 271 to 443 milligrams per meter squared and 2.5 for doses greater than 443 milligrams per meter squared. When breast cancer was considered separately, exposure to total body irradiation and chest radiotherapy increased risk, similar to what has been observed in previous cohorts of childhood cancer survivors. Doxorubicin was also associated with increased risk in a dose-dependent manner, with those receiving the highest doses experiencing a nearly six-fold risk, as was ifosfamide with more than a threefold risk. When the analysis was restricted to women who had not received chest radiotherapy or total body irradiation, the highest doses of doxorubicin had a hazard ratio of nearly 10, while the risk associated with ifosfamide was no longer significant. The doxorubicin-associated risk for breast cancer was even stronger when analyses were limited to women who had survived childhood malignancies associated with Li-Fraumeni syndrome, including primary cancers of the central nervous system, leukemia, and non-Ewing sarcomas. When sarcomas were analyzed on their own, cyclophosphamide was associated with increased risk in those whose cumulative exposure was above 9,400 milligrams per meter squared, as was total body irradiation and non-TBI radiotherapy. However, when survivors treated with radiotherapy were excluded, the cyclophosphamide-associated risk was attenuated. The findings of this manuscript are important and clinically relevant as we consider the next generation of childhood cancer therapy. These results validate the previously reported findings from the childhood cancer survivor study of increased breast cancer risk associated in dose-dependent manner with anthracycline exposure among women not treated with radiation therapy. However, a particular strength to this report is the investigation of specific chemotherapeutic agents rather than entire classes of drugs. As the authors point out, within each class of chemotherapy drugs, the individual agents may have unique drug-host interactions which lead to differing late effects profiles. Using these data allow clinicians and researchers to better categorize populations at risk and identifies important avenues for additional validation and research beyond radiotherapy. It provides more definitive targets for therapeutic modifications, and it also enhances the counseling we are able to provide to survivors about their level of risk. One of the difficulties in survivorship research is that we are constantly researching the effects of previous generations of therapies and attempting to generalize them to children currently undergoing therapy. The data presented by the DCOG later group is very relevant to the current generation of patients and survivors and should serve as a notice to other large survivor cohorts to begin the more rigorous examination of chemotherapeutic agents and soon immunotherapies. Since the number of individuals exposed to each chemotherapy agent is often small, international collaborative studies among survival cohorts will become increasingly more important and necessary to draw reliable conclusions. This report from the Dutch also presents data that are in disagreement with a recent study from the North American Childhood Cancer Survivor Study reporting temporally associated declines in subsequent malignancy risk secondary to decreases in radiation exposure. Ongoing follow-up of these cohorts may provide more definitive explanations for these differences that at this point remain unclear. As we move toward more collaborative studies with consistent data analysis strategies across cohorts, we will enhance the quality of available data and will allow for the most accurate characterization of risk for subsequent malignancies for survivors of childhood cancer. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.